Namaskar to all the viewers. Welcome to today's session of Critical Lines on our Young India Intensivist Forum. And today we have a very special guest, Dr. Puneet Khanna. So, sir is additional professor, Department of Critical Care, Anesthesia and Pain Medicine at the very prestigious All India Institute of Medical Sciences, one of India's leading medical institutes and ICU. Sir is the author of very popular books in critical care and anesthesia. He has authored six textbooks. He's also published a large number of articles, more than 300, with a H index of 25. And he is the recipient of several grants and awards. So, sir is a very popular and eminent figure in critical care in India and highly well-read. And I think this will be a great session for everybody. So, sir, starting with the first question regarding cardiac intensive care. Now, we have Takotsubo's cardiomyopathy. Takotsubo's cardiomyopathy is a under-recognized condition. It can present with hypotension, it can present with pulmonary edema, or both. And it is classically seen in elderly women who have emotional stress. However, it can be seen in other conditions as well. Example, we had a patient who came out of surgery, long surgery, and there was severe cardiac dysfunction after that. And that was attributed to the catecholamine surge during surgery. So there are many presentations and mimics acute coronary syndrome. So my question to you, sir, is how to diagnose this condition?
See, Tapesh, it's often under-recognized. Fine. If you look at, you cannot pinpoint. There are various clinical manifestations which they come with. As you said, your patient had underwent an acute surgery, had an acute stress. But most commonly, if you see the clinical features, we should look at three cardinal clinical features. One is acute substernal chest pain, another is dyspnea, and third is syncope. They come in that range somewhere around. The most common will be acute substernal chest pain. Then it will be dyspnea and syncope. Obviously, you cannot pinpoint on the basis of a clinical feature. They mask various other symptoms. And patients may experience heart failure, may have tachyarrhythmias, and bradyarrhythmia. Certain patients may even have a sudden cardiac arrest. Fine. So diagnostic criteria where the popular thing goes like they follow usually is that thing, Mayo's diagnostic criteria. And what they say is like all the four should be fulfilled in that. I just brushed it. So they say there is on echocardiography there is transient LV dysfunction. LV dysfunction can be in the form of say like akinesia, dyskinesia, or bradykinesia or hypokinesia. The wall motion abnormalities are typically regional and they extend beyond the coronary artery distribution. Then they say that you should have an evidence against obstructive angiographic evidence of obstructive coronary artery disease, or you should have evidence against a plaque rupture. But means that they should not be present. If coronary artery disease is found, the diagnosis of stress cardiomyopathy can still be made, but it should be like it's not in the distribution of the coronary artery. Third is like new ECG findings like ST depression, T wave inversions, and you should obviously rule out pheochromocytoma and myocarditis. There are few other diagnostic criteria as well, which takes into consideration, as you said, females, postmenopausal status, neurological disorders. And basically, these four things should be remembered.
Right, sir. So what about the echo? Mainly, I think echo is very important, and you are a master of echo. So on echo, sir, how will you just, eyeball and say on echo? Can we say?
It's difficult. You ought to look at the clinical features as well and look at you pinpointedly. It is very difficult to say like that. The
Right.
wall motion abnormalities are typically present and they should extend beyond a certain region. It should not be typically regional. Okay. But pinpointedly, it's very difficult just doing an echo and saying it's like a stress cardiomyopathy. You should have a cumulative clinical features and 3, 4 diagnostic criteria which we have, and obviously the little history which precedes it.
Thank you, sir. Then Sir, what about the prognosis in these patients?
Prognosis, see, the prognosis is same like as in patients with acute coronary syndromes. Most of the patients, they recover like 80% odd. Mortality is around about 8%. That too is a figure from the US registries. And long term, like 30-day mortality, again 7 to 8% is there. And recurrence does occur. The main things which should be concerned about is whether it presents with LVOT obstruction or without LVOT obstruction. These are the major clinical clinching points. And in these two identities also, we should like be careful in which to give inotropes and which not to give inotropes. Fine.
So,
So
if
if
you think about LVOT obstruction or iron drop, so just briefly, sir, about the treatment depending on the clinical presentation.
so see if it's very see management lies on three terms only. Basically, you will give a supportive therapy. You will wait for the resolution of an stress, whatever the stressor is, and LVOT obstruction affects the treatment of choice. So, if there is an LVOT obstruction, fine. So, LVOT obstruction, the clinching point should be you should avoid inotropes as they worsen the obstruction. In these patients, you should choose beta blockers as they improve the hemodynamics. Volume resuscitation can be cautiously done. Fine. And IABP may be used, which but may require close monitoring. Okay.
Right, sir. Thank you, sir.
And without LVOT obstructions, you can use inotropes. You can use dobutamine as well for LV systolic dysfunction. And mechanical support obviously is required. Further to follow is like heart failure management, which consists of say like oxygen, diuretics, vasodilators, ARBs, AC inhibitors. They are continued over 1 to 4 weeks.
Okay, sir. Thank you. Moving on to further cardiac intensive care, cardiac tamponade. So, cardiac tamponade is a condition which comes sometimes, and again, this is not picked up so easily. The
Yeah,
main features are dyspnea and general distress, and the patients are in hypotension. And a classic Beck's triad is described that of increased JVP, muffled heart sounds, and pulsus paradoxus with a low blood pressure. And pulsus paradoxus, if we examine the patients carefully, which often we don't, the pulse disappears in inspiration classically. And if you put the arterial line, the pulse, the systolic dip will be there in inspiration. So these are the classic features of cardiac tamponade. And the settings are, you can get an idiopathic pericarditis or tubercular or uremic or malignancy. So, sir, these patients are obviously in shock, what we call obstructive shock. So, how do we diagnose this cardiac tamponade?
so the Tapish, your previous question, which was there, can we just single pinpointedly say it on a basis of an echo? You can here very confidently go ahead with the echo findings. Fine. Obviously, the clinical triad, the Beck's triad you mentioned, muffled heart sounds, low hypotension, and signs and symptoms suggestive of cardiac tamponade. And identification of pericardial effusion is usually by an imaging. Fine. So echocardiography may either suggest of a chamber collapse and therefore respiratory variation in ventricular volumes, or inferior vena cava plethora is present, and there may be alterations in hepatic venous blood flow. So echocardiography is definitely helpful in diagnosis. However, conclusive diagnosis is always made again in combination. You need to take into consideration the hemodynamic and the clinical features as well.
Right, sir. So, can the echo miss the diagnosis of cardiac tamponade?
Difficult.
Yeah. All right, sir. So,
And
so there is something known as loculated tamponade. Does that make any difference? A fastly accumulating loculated tamponade?
yeah, that might not present with the same features as your classical cardiac tamponade.
Okay, sir. Thank you. So then, these patients are in distress, dyspnea, low blood pressure. They're often put onto the ventilator. So,
Yeah,
yeah. So what do we expect, sir, when they're put on the ventilator?
see, Tapish, with the ongoing day-to-day research, their new trials coming up, what they actually propagate is like, if it is possible, to try not to intubate and not to put on a ventilator and manage a drainage before that.
Yes, sir. So, sir, what possible adverse
See,
effects.
the positive pressure ventilation will exacerbate your cardiac tamponade physiology. It's very simple. The positive pressure will cause impaired venous return and impaired cardiac filling. So, acute hemodynamic collapse may occur due to the drop in the preload and the cardiac output. So, therefore, they say if it is possible, do a pericardiocentesis first and then intubate the patient, then put the patient on positive pressure ventilation. Because when you place a patient, intubate the patient and place it on a ventilator, the as I said, decreased venous return, decreased preload, and decreased cardiac filling leads to decreased cardiac output, leads to hypotension, and afterload is increased due to positive pressure again due to increased intrathoracic pressure. So, especially in hypovolemic patients, they may collapse. They may collapse. Reason being, it makes the heart very difficult to contract. Fine. And above all, we might have used certain sympatholysis, like to intubate, we use certain drugs, they may cause sympatholysis, which causes further vasodilation and a decrease in BP.
Right, sir. Thank you. So, moving on to the intubation and decreased blood pressure, sir. We had this Intube study, and I think Dr. Maitra from India was one of the lead authors in that, and that showed very clearly that hypotension is the most common complication after intubation for so many reasons which you enumerated just now, which apply to intubation in a patient who does not actually have even obstructive shock. So I think those features you have enumerated clearly why patients develop hypotension when they go on to the ventilator. And Intube study found that it was not hypoxia, but hypotension, which was the commonest perioperative, peri-intubation, sorry, complication. Now, sir, there was also this trial which showed, that even if you give these patients volume, it does not help. One. So, any comments on that, sir? How we should manage patients whom we are going to intubate so that they don't develop hypotension?
See, Tapish, off late recently two trials came. Again, when you gave me a prompter, though had gone through it. These were prepare trials, prepare and prepare two. These are the latest ones. Fine. So they both the studies, prepare and prepare two, investigated whether administering a fluid bolus before tracheal intubation could reduce the incidence of cardiovascular collapse. However, they had certain differences in their methodology, but both the studies made a conclusion that routine administration of fluids, fine, before intubation or just prior to intubation does not reduce the hypotension or the collapse that might occur after intubation. Therefore, they suggest like better to individualized hemodynamic management, possibly favoring vasopressors over the fluid management. Fine. So if you are trying to intubate and give try, drugs like propofol, benzodiazepines, or opioids, better to go ahead with an vasopressor beforehand and a tomidate, which is much more cardiostable.
Yeah, great, sir. So thank you. Moving on now to another area, a neurocritical area. So, sir, regarding targeted temperature management, the pendulum keeps swinging. And now recently
Um,
we had the last TTM2 trial. So, what are the current now recommendations for control of temperature after cardiac arrest, sir?
Tapish, it will always, pendulum will keep on swaying. Let us keep into consideration, like, yes, it is required, and it is required in those patients, those who are comatose after ROSC, return of spontaneous circulation. Fine. फॉलोइंग अ कार्डियक अरेस्ट, पेशेंट जिसको कार्डियक अरेस्ट हुआ है उसका स्पॉन्टेन रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन हो गया है और वो कोमाटोज है, तो इन पेशेंट्स में हमें करना ही करना है. प्राइमरी गोल इज टू प्रिवेंट एनी न्यूरोलॉजिकल डैमेज एंड टू रिस्टोर न्यूरोनल फंक्शनैलिटी. फाइन. अब इसमें लेट्स नॉट गो इनटू विच ट्रायल गोज फर्स्ट, विच गो ट्रायल गो सेकंड, अभी लेटेस्ट क्या है, लेट्स टेक AHA and I think it will be sufficient. AHA says like any comatose patients after a cardiac arrest had return of spontaneous circulation should undergo target control temperature management, and they suggest anywhere between 32 to 36. Recommendation is based like maintaining the temperature in this range can improve neurological outcomes. However, all the societies, other people may not agree with it. Fine. As like Australia, New Zealand, they say like there is no benefit of between 32 to 34. They say like you should try to maintain somewhere around 36 to 38. That will be helpful in prevention of this thing. 36 to 37. Sorry, not 38. Fine. So what we can say safely to conclude it, it is required. Yes, cardiac arrest, ROSC, comatose patients, somewhere between 34 to 36. No benefit has been conclusively pointed out between 32 to 34.
Thank you, sir. Now I'm moving on to something which is more practical about arterial line and central line. So, as far as replacement of central line is concerned, the IDSA and the bigger guidelines from Europe and America do not recommend unless there's a complication. But this does not apply to our ICUs and other LMC ICUs where infection rates are higher. So, what kind of policy should ICUs adopt in changing central lines?
See, Tapesh, this is a very practical thing. अब हम यहाँ पे if we start quoting CDC or IDSA, that is an ideal environment. Fine. And as per the guidelines, if you say for the sake of this thing, what does the guideline say? We should not deviate from it. They say that it should not be changed, removed, or anything unless and until this thing. It has got some infection, it has shown some malfunction, or it has been occluded. Fine. But when you take this thing into our Indian setup, I think we should वही 5 स्टेप्स होते हैं. हैंड हाइजीन होनी चाहिए, एसेप्टिक टेक्निक होनी चाहिए, स्टेराइल ग्लव्स होने चाहिए, मैक्सिमम स्टेराइल बैरियर होना चाहिए. Forget about everything. Daily inspection of the CVC site should be there. In
So,
our lower middle income group settings, preventive measures are these only. Hand hygiene, aseptic condition, using sterile gloves, maximum sterile barrier, fine, आप gloves पहनो, सब कुछ करो. But day to day basis, whenever again in the Indian setup, do an examination of any invasive line that you have placed the site every day. Fine. And the day you find it shows some pus points, it shows some infection, or it has malfunctioning, or it is occluded, just remove it.
right, sir. So then, do you think ICU should make their own policy? Supposing you're getting sepsis, line-related sepsis in 7 to 10 days on an average with a
Remove it, remove it. If you cannot find any other reason, you cannot attribute to any other thing, just remove it.
okay, sir. So then, moving on to arterial lines and arterial catheters, do you think we should remove them at some particular specific times? How should we be guided in this?
Same thing, Tapesh. See, arterial catheters may last for a longer period. Fine. Then your smaller arterial line. If I'm, no, sorry, other way around. The longer one, the 10 centimeter one may last longer. The problem is we place it and we forget it. Although we might keep on flushing, we might keep them on an heparinized thing, we should try to assess for the proximal or and the distal circulation both. What inadvertently happens is the thrombosis occurs, and then when we notice by the time in arterial lines you won't find infection so soon. Fine, but the thrombosis occurs, and when then we realize that something bluish is coming up, and then we remove it. So it is again better to examine the site in the arterial line proximally and distally both.
Okay, sir. Thank you. Final question, sir, about myopathies and weakness. That's an
Yeah.
important area, and it also affects weaning. So we have the critical illness neuromyopathy, which develops in many patients. And then we often have patients who are wasted, who are suffering from malnutrition. So there are two kind of myopathies here. One is the critical illness myopathy, and there can be a myopathy due to poor nutrition. So how will you differentiate in the clinical setting in the ICU between these two conditions?
See, Tapish, there are two different types. One is you can say like critical illness associated myopathy, which we say as CIAM. Fine. Or you can say there is something called as critical illness polyneuropathy, which is due to the like malnutrition related myopathies or other muscle disorders. So if you say like critical illness associated myopathies are usually affecting muscle function, leading to proximal weakness. Fine. These are triggered by prolonged ICU stay, neuromuscular blockade, steroids. And if you look at the other part of it, which is a peripheral nerve disorder, if you say, this is between the two. So that when CIAM, which I am saying, causes proximal, and this will cause a distal neuropathy. Fine. Distal neuropathy in basically critical illness polyneuropathy, CIPs. Fine. And if you want to distinguish between the two, what you can do is an electromyography and nerve conduction studies. And then there is something, this is called malnutrition related myopathy, which develops over weeks to months, which occurs due to muscle atrophy, electrolyte imbalances, and more gradually over a period of time. Fine. So I have named three identities right now. Okay. One is critical illness associated myopathy. One is critical illness polyneuropathies. Fine. One is proximal, one is distal. Another is malnutrition related myopathy, which develops over a period of weeks to months due to malnutrition, electrolyte imbalance, and it might have mild elevated creatine kinase. To distinguish, you need clinical history, you need electromyography, you need nerve conduction studies. And if you want to go more, you require, for a definitive diagnosis, you require a biopsy.
Right. Thank you, sir. Just wrapping it up, sir. What is the outcome for critical illness, neuropathy, and myopathy, sir?
Outcomes like recoveries and outcomes, some recover partially, and if the recovery periods may require 6 to 12 months. Fine. And they develop within weeks and recovers within months. Uh, Severe cases may require even 1 year. And mortality, if it is, if you say, oh, what, I cannot give you the number right now, but yes, it is linked to it. And obviously, patient becomes ventilatory dependent. It's difficult to wean off the patient, and when you have patient which is difficult to wean off, recurrent infections, recurrent VAPs. So the what is it, neuropathy itself increases the chance of mortality.
Okay, sir. Thank you very much. And that was the last point for discussion. I thank Dr. Puneet Khanna, sir. Very nice. Thank you so much, sir, for your time and all the explanations. I thank the viewers for their patience and for their joining the seminar. Thank you so much.
Thank you, Tapish, for keeping it short and sweet.
Yes,
Thank
sir. It's always better if we keep it short and sweet.
you. Okay.